everybody, and thank you for being so punctual and on time. Our next speaker is a little unusual in her journey towards passive self-ligation, in that she was using twin appliances, and as she was getting ready to start with Damon, was intercepted by one of our Insignia team at an AAO. And when she saw Insignia, it made so much sense to her that she actually went straight down that path. Today, she's one of the leading users of the product globally and has treated over 2,000 cases. She practiced and graduated from Ontario in Canada, and we're looking forward to having her share some of her cases. Now, one of the things about Insignia is that it is customised and individualised for every patient. Now, ladies in the room, you'll have to help me with this, but Sonia was telling me that when she speaks, she has to buy a new dress every time, because females in the room will notice. Most men struggle with that concept. You know, women tell us they need a new dress every time they go out. It's like, why can't you wear the old one? But I think you'll all agree, fashion sense is impeccable. So Sonia has a new dress for today's presentation, and we look forward to hearing from her.
Thank you, Colin. Thank you for the lovely introduction. It is a new dress. I hope you like it. It's my Asian-inspired theme. I felt it was speaking Thai to me when I saw it in the store. I want to thank Sandra for hand-picking me. I didn't know I was hand-picked, but thank you, Sandra, for Sue, my agent, who is in charge of education, who always asked me to come and do these lovely engagements, and to Colin and Bruce, who showed me an amazing time when I was in Australia for the past 2 weeks. I consider myself a student more than a teacher. I teach at Western University, where I graduated from. I have been in practice of my own clinic for 18 years, and for the past 6 years, I have done Insignia. It took about 2 years to transition my practice from what was a SmartClip practice into Insignia, so we always used indirect, and as Colin said, it made sense to me because right at the moment I was looking at purchasing variable torque. I was going through all the logistics of what I would have to put on the shelf, and we were doing indirect. I looked at using a digital setup to analyze cases, and I saw a Damon speaker, and I thought, I can't do that. And I need to do that with the teeth. So the passive self-ligation was told to me that SmartClip was passive self-ligation. I don't know if anybody here has used a SmartClip bracket. It is not passive. There's a great deal of friction in that system, and it works like a twin bracket, basically. And so passive self-ligation was also new to me, and the Damon principles and philosophies apply to Insignia. And so there was this huge learning curve for me. And so it took me years to get up to speed with this. And so my talk today for you is solving the patient puzzle for simplified mechanics. And I want to tell you the answer to this puzzle. Shh. I'm going to tell you the answer to the puzzle. It's Insignia. Okay? So there, if you're tired from lunch and you need a nap or you want to go to the pool, you can go, because that's the answer. Now, in an hour and a half, can I train you in Insignia? No. So my hope today is to show you cases so that you can see what I see. Because by studying what I'm seeing, I realize many things that we know to be true in orthodontics is now to me like false knowledge. And I think to myself, this is worse than ignorance. This is a quote from George Bernard Shaw, that false knowledge is worse than ignorance, because we base everything about what we know in orthodontics on old cephalometrics, on old technology from 100 years ago, from two doctors who treated like this and said, do it this way. Even Dr. Damon, this is how the avenue goes, is a doctor steps forward and says, this is what we're doing, and this is how I do it, and this is what I see. And my hope is that people use Insignia so that we have more eyes to see with, so that people can contribute and show what they see. Never to say this is the only way to treat somebody, okay? How do we begin to solve any puzzle? If I had a jigsaw puzzle, if you had a 2,000-piece jigsaw puzzle and you dumped it out on a table and your purpose was to solve this puzzle, how would you begin? You would probably start flipping the pieces over. But definitely, you would want to know what the picture looks like, wouldn't you? Because we always start by studying the solution, don't we? When we have a puzzle, we look at how we want the solution to be. This is my daughter. She is here today. You'll see her walking around. She's 12. She'll be 13 this year. And for Christmas last year, she got a Rubik's Cube. And she became obsessed with solving this puzzle. Now, we all know what a Rubik's Cube looks like. We know what the solution looks like. And so she now develops a system. She's not just randomly moving the pieces. Her system starts by solving the white side first. Every patient presents to us as a puzzle. And what do we do as orthodontists? We study the problem at length, not the solution. We study and study and study the problem. This would be like writing down on a Rubik's Cube every color that was next to every color on which side and mapping it out and graphing it and photographing it. Why? Is it going to help us get to the solution? This is like teeth. Teeth, jaws, muscle, bone, all the same parts, messed up in different ways. So what? My treatment plan is Insignia because I know the solution to this puzzle. Instead of just imagining the solution in our minds and hoping to gain an acceptable result, hoping to gain it in an acceptable amount of time, how do we know when we're done in orthodontics? What if we changed our focus? And instead of focusing on the problem, we focus on the solution. Right? This is the difference with digital. This is what has happened. This has transformed me, the way that I think about how we approach problems in orthodontics. Digital has changed from looking and studying the problem, immersing myself in the problem of the patient. And then the next patient and looking at the problem. Studying and describing the problem. And only here just thinking, what do I want? This is always where we think that we have to know, imagine what we can do for the patient. Think only in your mind, what do you think you can do for this person? And if I'm better than you, I'll get a better result than you, right? Is that how it's explained? And so the orthodontic solution is as specific as this Rubik's Cube puzzle, okay? It is something that we will all agree on. And even if that we do not agree, how many people here would like the 6 keys of occlusion in every case they finished? Yes, Dr. Chang is the only one. None of you, you only want 4 keys of occlusion, you don't want 6? Do you know the 6 keys of occlusion? Andrew's 6 keys of occlusion? Yes? These are standards. This is what is a class 1 occlusion. It's described. It is the standards that we measure the ABO case on. We all want a smile arc. Is anybody in the room trying to flatten the smile? Trying to make a reverse smile arc? No. We are all trying to make a smile look natural. We all want TMJ health, don't we? What does that mean? Do we think we have no impact on this? Do we think we can't control things? This means a functional posterior occlusion to establish a good TMJ health for the patient. We want periodontal health. We want roots centered in bone, right? With good attachment. Nobody is purposefully trying to push the roots out of the bone. This would be nonsense. We want facial balance. We want the patient to be able to close their lips. We want a good profile. We want good vertical thirds. We want good facial symmetry. Nobody, if they could get it, would not take these, right? And we want stability. These are the sides to the puzzle. These are so well defined in and of themselves, what our goals are. And we have studied these things very little. We are only to imagine these things for every patient. Just wonder in our mind, will this be stable? Can I get the cuspid in? I don't even know about her jaw joints. I hope the perio improves. If I don't tip the teeth too much, she might not need a graft. These are sort of these floating questions that we just surround ourselves with, and this to me is the false knowledge, is trying to take this solution and clearly, because we can all identify the solution, right? If any piece is not fitting, we all see it. If I show you a case and something is off, a lateral is tipped incorrectly, a molar is not seated, something, the midline is slightly off, there's a tip problem, we can all see it. Why is that? So we all know what we're looking for. We are looking for ideal. That's what we want, an ideal normal, which is what Andrews based straight wire appliances on. And the 6 keys are based on that. And all of those goals are consistent with dentistry. That's what's beautiful. What we don't agree on is how to implement the solution. So this is where the profession gets into a little dogfight, right? With a distalizer versus an expander versus passive self-ligation versus active clip or lingual or Invisalign or whatever you want to use, right? So why Insignia, right? Here's my goal. My goal is to get the solution predictably and reliably. I want to be confident that I can fix the problem, not wonder if I can. I want to do it in the least amount of time. It matters. People's lives are going on and they're busy and they don't want braces for a long, long time. I want to do it in the least number of steps so that I have little work to do. If you're going to pay me a sum of money, why do I want to work harder for that money? So that I feel like I earned it? I want to work the least. I want to do it with the fewest number of appliances and adjuncts because those things cost money. They take up clinic time. We have to fit them and take care of them. And patients have problems with them and they have side effects. So the simplest that I could do something, and all of this means that I will do it the most profitably. So, I love Dr. Lin's comments this morning, is show me a case. If someone here will show me the technique that will do this better than the way I am doing it, I would change tomorrow. Okay? I am not married to Insignia. I don't get paid if you do Insignia. I'm paid to speak here as a KOL, but I don't have a vested interest other than my interest in advancing orthodontics, in trying to see what is this showing us? What is this digital information showing us? Okay? With the orthodontic puzzle, it's like any system. So my daughter likes the white side first on the Rubik's Cube. You have to sort of start somewhere. With a jigsaw puzzle, you would start to flip the pieces. With braces, start with the teeth first. Okay? Solve the teeth first. It is amazing how much simply a perfect alignment of the teeth will go to achieve a correction, an occlusal correction. We look at orthodontics all compartmentalized, like we have alignment and leveling, and then we do some mechanics, but the alignment of the teeth is the mechanics. The second she moves the puzzle, she's making moves to solve the puzzle. The second we glue something to someone's teeth, we are starting treatment. We are making moves to solve this puzzle. And if we are just guessing, my best guess, I hope what I get, I wonder, this is where I start. This is the 6 keys of occlusion. This is a class 1 denture setup. When I started with Insignia, I thought, I have a custom appliance now. Every patient is going to have their own special prescription and their own special result, everything. And I'm going to do something different for you, something different for you, something. No. Do you know after 500 cases what I realized? Everyone's the same. A class 1 occlusion looks like a class 1 occlusion. If you have a set of models on your desk for education purposes to show patients of a perfect teeth setup, how are you going to do your setup? Any different than that? If I focus on the goals, if my solution involves having the 6 keys of occlusion, then that's where I start. Now, look what nature has given this person. Watch this movie. Watch what happens specifically, and I want you to see at the molar what is happening. Look at how the lingual tip on these molar teeth are rolled in, and I am uprighting things. Why am I uprighting things? Because one of the 6 keys of occlusions is a level curve of SPE. So I level the curve. I level the curve of Wilson. Dr. Burney talked about putting this curve of SPE right here, and you still put that in, and you know why? Because that's straight teeth. Because when the marginal ridges of the upper 6 and 7 align, you see a curve here, okay? People say, oh, Sonia, you set your teeth really heavy, heavy occlusion. I say, it won't look, you can't do that. I say, this isn't prosthodontics. This is orthodontics. I don't even look at the occlusal setup. It doesn't matter to me. I just want heavy contact. I want the teeth to contact so that I don't have to do any closing on the person. But this is how I set this person up. Here's how she walks into the office. This is Ainsley. So you can see we have a little mild class 3. Compared to this population, this would be a dream, right? This girl walks in your office, you're like, yes. That's an easy one. But we have this blocked out cuspid, and you can see her teeth are retroclined. And she's got a mild class 3. This is where she finished. This is the day I take her braces off. And this is what got me hooked on Insignia, is I never had to cut wires. I don't have to do closing elastics. I don't have to do all this settling. The bite simply drives the correction. Once we start uprighting teeth, and teeth are functioning together properly, the teeth move together because this is the play in the system. The periodontal ligament is widened on the top and the bottom, and there's some play between the wire and the bracket slot. This is the 6 keys of occlusion right here. Level curves, a class 1 molar, proper angulations and inclinations of teeth. So you can check this. You just do this on your setup. And it is standard. So I'm not guessing where do I place her teeth. We have tight contacts, no rotations, and level occlusal curves. Okay? So we start here. We're going to set the teeth ideally for everyone. Every patient. Why? Because I want the same result for every patient. I'm not trying to make someone not have this. I don't want 5 keys. I want 6 keys. So when you look at this, play from the beginning to the end and watch the movie play. Look at this. We all know what this looks like. Look at this roll in and this cuspid blocked out. This is a collapse which causes this. This compensation is from muscle function from her transverse. This tooth, to me, is the key to malocclusion. I will say that now. I think that the lower first molar is a qualitative common factor in all malocclusion. It is rolled lingually 100% of the time unless it's in a labial crossbite, like a dental, one single tooth dental crossbite. But the malocclusions that we treat all have this in common, thousands. And to me, when we think about what's happened to cause this, because nature didn't intend this, it intended this. And I simply restored this girl to what nature intended by moving the teeth back. They moved in, I moved them back. It's very simple. This is her face. So these are her teeth, class 3, but look how retrognathic she is. Her whole face is retrognathic, and she has the thin lips. This is her after treatment, just from braces. This is her smiling here, and this is her smiling here. Now, we drop this forehead line. Oops, I'll go back. Sorry. We drop this forehead line and our E-plane because this is part of Larry Andrews' 6 elements. Is this forehead line? Where do we want the upper incisor to fall? What I want to show is this. See, she's facially back. Look how much of her nose is behind here, her nares. Okay? And now look how much has come forward from moving her teeth. She never had a face mask. She's not growing tons. This girl was 12 when she came in. This is 13. Here's her nose. Here's her nose now. Look at the tip on her nostril versus here. Look at the change in her lips. Okay? How much dished in this is. I mean, nobody would take teeth out on this girl. And then how much more forward they are here. But look what I did with her. I missed something very important. She has a beautiful change of her midface, which we know this is alveolar deformation. A light force, her teeth erupting into her mouth, grew in this arrangement. The lower molar pulled in, and in her case, her lower teeth moved back, okay, in her face, which hampered all of her growth. All I did was use a light force to move it back out. Now, do I love her smile? No. She has an incomplete smile arc. And why is this? Because I finished in a TMA. And this I learned directly from Dr. Damon and also from Dr. Stuart Frost, who is a Damon master. And Dr. Damon's technique is to go to a 1925 steel. Why is this so important for the smile arc? Because if we do not express all of the posterior uprighting and the width that we want, we will have slightly flared incisors. And we will have an incomplete smile arc. And that's what I see with her. Okay, so although I love her occlusion, when I looked at her and I thought, yes, we're done. When I look here at these photos, I think, okay, I would have done that differently. This is Ainsley's treatment summary. She had 13 months of treatment from the time I put her braces on till the time I took her braces off. She had 9 visits to my office, including her banding and deband. She came in 1 extra time for a broken bracket. She used, and this is the line that I want you to see because this is how I treated every patient basically that I will show you today. Insignia Custom SL. What that means is it's the custom torque bracket, anterior and posterior. I do not use snap-link tubes or standard tubes or any other thing other than the custom because I believe that it's the lower molars that are key to unlocking the occlusion. To do this quickly, those teeth have to upright. And if they don't have the torque value that I need on there to do that, coordinated with the archoir, I won't do it. Okay? She had an Accellident, which is a vibratory device, a micropulse device to help soothe teeth and speed treatment. I'm not certain it sped her treatment along, and I don't do research. I'm a user, like you. I have a clinic, and I treat. And then I just look at what I do. And this is what I'm doing. So if somebody knew a better way, and you could show me, this I would really appreciate. We disarticulated her, and I've thought largely over this last year how exactly I disarticulate someone and which teeth I put it on and for how long. Elastics. I'm really rethinking elastics as well. Okay, we'll talk a little bit about that. And a stepwise progression through her archwires. It's the same really every time. What work did I have to do for Ainsley? I had to reposition 2 brackets, put on 1 torque spring, and add 2 step bends. One of the step bends was to correct one of my repositions. That's kind of embarrassing. But she had a total clinic time of 3 hours and 30 minutes to address her malocclusion. That's what she started with, and this is every visit. That's the day her braces went on. 2, 3, 4, 5, 6, 7, 8, 9, debent. Here I put a torque spring on her 1, 2, and I put it back on here because I still didn't like the torque on it. I repositioned these 2 teeth right here, and then I did a step bend on this tooth to fix my repo, and I put a step bend on the 2, 3. This is not difficult work, okay, to figure this. What I want to show you, and watch for this, is that usually by appointment 3, so when I say 1, here I mean initial, we put the braces on, visit 1, visit 2, visit 3. By this 3rd visit, on every case, practically, that I treat, I'm not worried about Ainsley, right? If this girl walked back in your office, looked like this is at 4 months. Are you worried that you're going to solve the problem? No. Because you can look at that and see this case is totally under control. The teeth are coming together. Her function is driving the correction. Everything's looking well. The bite is coming together. Teeth are uprighting. Whew. Right? How many times, I can't even tell you in a day, with SmartClip, did I sit down and start sweating with when someone opened their mouth. And I thought, OMG, what is happening? And I would look back at the patient's pictures and see, what did they start with? Because we never used to take photos at every visit. And I just started doing this, like, I'd say 2 years ago when I started teaching, because some of my cases, Chris, can't go in the IJOI because we missed a couple, like I missed a visit or something, and then I don't show every single step. But I'd say we started to do this routinely, is to take these photos. But before, I used to look at a case and wonder, oh my goodness, the case is going crazy. Nothing's coordinated. I don't know what's happening. And this is supposed to be braces. This is the world of orthodontics. That it's just, there's this element of like, who knows what is going to walk back in. And you know what walks back in? The 20% of patients who have the wrong stuff on their teeth. The wrong stuff in the wrong place. And they have crooked teeth. So imagine your ideal molds, right, that are on your desk, and you just take 4 teeth at random in the posterior, and you tip them, and you torque them, and you rotate them, and you extrude them. Now try and put the models together. You can't. Because the alignment, independent of each other, the alignment of the upper and lower teeth is critical to solving the occlusion. Because they have to fit ideally. We want an ideal fit. So we need the teeth to fit ideally. So this is what Insignia will show us. But we want to solve the teeth and remember the smile, right? We don't want to just neglect that smile arc because we have the same goals. So here's a patient, and this is Teresa, and we would say, well, what did we discuss with Teresa? Teresa did not have a thumb habit, and I thought for sure she did. But this is her movie play. Now, you would say, Sonia, come on. That's not going to happen, right? Because it's like Dr. Bernie said, we have to think realistically. This may not express itself exactly. And if you ask me how much vertical change, if I program in here how much vertical change, I can tell you, I programmed in on her 5 millimeters of vertical change of her maxillary anterior teeth. Is that what was expressed clinically? Clinically, I saw about 3 millimeters of change. I want you to look at her molars, though. Look at what happens. Look at this tooth. What do you think is the cause of her open bite? When Dr. Lin says you can't intrude this tooth, Dr. Lin, you can. You can. Insignia. If I took this tooth and I put it down here and I buried the marginal ridge, I've done it by accident on many, many cases where I just didn't check if the 6 and 7 were level and the 7 was submerged. And you know what I got clinically? A submerged lower 7. It intruded the lower 7 dramatically. A 1 millimeter change here will make a 3 millimeter change there. And this, again, we want a nice class 1 occlusion. It always looks the same. So I'm not guessing, do I have, how much do I think Teresa will get? Do you know how much Teresa will get? How much she gets. Why am I obsessed with the problem? I put her in an ideal solution, and I stand here. And I say, okay, Teresa, you're like this. Come here. Okay? This is what I want to see. And if her correction stops short of this, I am able to recognize it very early in treatment. Very early. This is key. Not at 2 years in treatment when she still has an open bite and I'm wondering how I'm going to get it solved or tell her that's all we can do, because this is her bite. This is the day I take her braces off. This is the alignment of her teeth. Okay? So you see this molar where we've leveled it. Now, when you look at this from the movie to this occlusal, on the 6s and 7s, I never looked there. I only started to see the movement of the molar and recognize that this is how to control the occlusal plane. This is where the occlusal plane change is happening. And this is where we have to move the molars in order to gain the correction for the anterior teeth. We focus on the anterior teeth, and we're obsessed with them to the point that we need special torques all for the anteriors. What about the posterior teeth? Here's her smile. Now, she was 15 here, 16. So she didn't grow a lot. And I did discuss with her. What did I say to Teresa? No problem with Fix Your Bite, no problem. No, I said, we might have to use some TADs. We might have to use some meows. I did do a lot of meow treatment, actually, with my Smart Clip. It worked much better with Smart Clip because of the friction. If you put a meow archoir in a passive, it's way too slippery. There's all kind of side effect to movement, and you have to really chain like crazy to make it work. Or surgery, right, for an open bite. But I've had jaw surgery. I've had so much ortho, I don't even want to discuss it. And I want to fix the patient non-surgically. And we did. Here's her smile. She has a little bit of gingival bump here just from irritation. Something was stuck on her braces that day. This is the day we took her braces off. This is the change in her. And see how her lip proportions have improved. This proportion here versus here. Every change we make, we can be so subtle and not understanding what makes exactly the patient look so much better. This is her overjet correction on her open bite. Okay, so when this patient walks in, are you just like, yeah, we do some insignia. We fix this. Or do you wonder how? Do you just start right in with TADs? Why? Because we don't know what's possible. We think we know what's possible. But we can only guess what's possible. And when you try, when you set something up ideally and just try, with nothing more than insignia, then we see something great. What would I do different here? I would use some IPR here. And because I ran an elastic here a lot, you see this little irritation on her. I could have avoided that and maybe improved this a little bit. This is her movie. Look at the 4, the excess buccal overjet, just like this. Can you see how she's skewed to one side? And now, not. Watch this movie. Do I need a study to tell me that when I place the teeth in an ideal position, that I am going to go from here to here? If the patient shows up, wears their elastics, and brushes their teeth, and keeps their braces on. Now, I wonder to myself, why did it go so slow? But this looks just like this to me. And I remembered her smile arc this time. The smile arc is important for the incisors to follow the lower lip. That is a smile arc. Now, what's weird is the lips will change as we move the teeth. So why spend so much time on the problem? Studying the problem and the lips and the positions of the teeth when we're going to move the teeth. And once we move the teeth, it's going to move the midface. It's going to move the lips. It's going to change everything. We only have to be understanding of what we want to see and then looking for it. And if we work out so that we have the right stuff on the teeth in the right place, then we can actually use our minds to focus on our solution, that we're getting what we want from our solution, not still trying to figure out the problems chairside. This is not what we want, because we can see that when we get to the end, we don't even know if we're done. We wonder to ourselves, am I done? You say to the patient, says to you, I'm done. Then you're done, right? But we have what kind of objective criteria for that? Here's Teresa's treatment summary. She had 16 months of treatment, 9 visits, including her banding and deband. She had 4 extra care visits for wire pokes and a bracket repair. One bracket repair and 3 wire pokes. She had Insignia Custom SL, disarticulation, elastics, and a stepwise progression through the custom arch wires. So we started with an 014, that's my typical wire that I will start with, and then go 1425, 1825, 1925 TMA, 1925 steel. She had 3 repos, and I did no bends or curves to her arch wires. And her total clinic time was 3 hours and 50 minutes. We book 1 hour to put braces on and 1 hour to take braces off and do all of our records and all of our hygiene and all of that, and glue in a bonded retainer and so on. So there's always these 2 hours. My goal is to get treatment under 3 hours. That's what I'm focusing on right now, is what is slowing down this correction, because the number of appointments and the time in treatment is important. This is Teresa's treatment progression. This is the day her braces went on, and as we go forward. Now look here. As she comes in, 1, 2, 3, she still has some glue on her teeth here, and I took it off at this visit. I feel good with Teresa at appointment 3. If Teresa looked worse, open, not responding, okay, to this alignment, then what? Then at 4 months, I can have a conversation with Teresa and her mom about what I want to do to try to fix their open bite. TADS, whatever it is, surgery, we'll see, right? But I'm not going to have this conversation at 2 years. Once I try something, and nothing's worked. I know it's going to work right here, okay? And this is so comforting. I can't tell you. In clinic, this feels so good that you never see something, you don't see, this does not look wacky at any moment, okay? And they don't. They get better every time. And if it looks wacky, I look that kid in the eye and I say, you didn't wear your elastics. I know they didn't, because I know if I have any kind of normal at all, anywhere where I know it's just a moderate problem, I know they didn't do what I asked. I don't have to guess anymore. This is so good. It's so good for your confidence to know that this will get solved, that you know what you're talking about, you can predict it, and you can do it reliably. This is a good feeling. So, we want to solve the teeth and remember the smile, and we also want to make the jaw joints happy. Remember, that's our other goal, right? It's talking about how do we get our TMJ health? What are we doing to make sure that the jaw joint is going to stay healthy and happy? This patient came to me, and her concern, besides her crooked lateral, was that her jaws were hurting her, okay? And this is typical of a patient that you would see maybe who is complaining of jaw joint problems. One is it's usually a female, with a shift. Dr. Berney's depiction of that lower jaw position, of what happens to the lower jaw when we have transverse deficiencies. So remember what I said. Every patient has this lower rolling in of the lower molars, and they have transverse deficiencies. And these transverse deficiencies are happening in the anterior as well as the posterior. Okay? And the lower jaw is just hanging in a sling of muscle in space. It is at the mercy of the teeth erupting. And if it shifts, a lot of times we can see, here is the problem. We say to people, oh, we can't promise that we're going to fix your jaw joint problem, but 9 times out of 10 in a patient like this, we are going to fix the jaw joint problem. You can see that she has a full step class 2 on this side. She has some thin tissue here, her midlines are off. and class 1 on this side because of that shift of the jaw. It's loading her jaw joints. This is, again, the day of her deband. This is the day I take her braces off. This is Janine. So look from the 2 to the 1. She's a full unilateral class 2 step. Now, in my education, I would have needed a distalizer. I probably would have used something like a pendulum with a plastic and a band and a TMA spring to distalize and expand and yada, yada, yada. A lot of stuff, okay? Because once you start doing that, you have to then, upright those teeth, and there's side effect movements and back and forth and on and on. Remembering that the mandible is at the mercy of the erupting teeth. Here is a view that you do not see a lot, and this is why. Well, one, I'll show you that, but we don't use differential posterior torque. I mean variable torque for posterior teeth. But we see differential posterior torque in almost every patient, especially this patient, who is unilateral. Her mandible is shifted. She will have completely different torque values that she needs on the right to the left side in the lower posterior. And what will probably everyone in this room do who uses a standard prescription? You're going to put the same thing on the posterior teeth on the right and the left side. Do you have variable torque for the posterior teeth as a standard in your practice? Probably not. Nobody has ever even discussed that with me. Everybody talked to me about variable anterior torque. We have to select all the torques for the anterior teeth. Like the anterior teeth are the most important things that we have. They're the problem. But if the problem is the lower posterior teeth, and one side is really much more in than the other, and we put the same things on those teeth, how are we going to solve the problem? How will the transverse dimension be corrected? When we just have to add with a wire, expand one side, do we think nothing is happening on the other side? How come the midline isn't coming on? How come the class 2 isn't being corrected? Because we conclude it's skeletal. Because the patient has a skeletal asymmetry. Easy. But that's the assumption. What if it's just because we don't have the right thing on the teeth? If you look at her, how she presents, look at this side versus this side. This side is rolled in more than this side. And her midline is over to that side, and this side is crushed in. Okay, look at this lateral, and these teeth tip back. One side is different. Now, if you look, just look at her occlusally, you say open. Her molars look, mesiodistally, they look symmetric. Her upper molar looks pretty symmetric here. This is her class 2 side. It doesn't look like her molar has slid forward half a tooth width, right? So we would misdiagnose this case likely to say she has maybe a skeletal asymmetry or something like that, but she just has differential posterior torque as a result of a lingual collapse of her lower teeth. Look at this view. Watch this movie play. Imagine the lower jaw, what's happening as this is rolling in. And all I'm doing is simply uprighting the teeth. They can be addressed by unlocking the anterior and posterior transverse deficiencies that are responsible for deflection of the mandible in all 3 planes of space. You can get rolling in of a lower cuspid like Dr. Burney showed from a setup error. You can also get rolling in or lower crowding in any PSL system, in the Damon system, when you are attempting to correct a class 2 that does not have adequate anterior width in the upper cuspid region. If your upper 3 to 3 or 4 to 4 is not wide enough to accept the lower 3 to 3 when it is upright and you are running class 2 elastics, you will cause lower crowding. You will cause some flaring. It's inevitable because the transverse is what is causing a lot of this rotation and deflection of the mandible, and that is what can lead to some TMJ problems. Incomplete posterior uprighting. So if we look at this, sorry, I'm just going to go back a slide. Incomplete posterior uprighting will not allow for proper transverse coordination of the arches. If you were sitting there with a case and you think that you have to reshape your wire and recheck your wire because you're fighting a unilateral crossbite, okay? Your midline is off, you have all the teeth aligned, it looks good, but the case will not come together. You need more torque on one side on the lower. And then you need to widen on both sides on the upper. That is what is happening. Okay? We just clinically cannot visualize it sometimes because we don't watch movies of teeth as they're moving. We're simply saying open. And when a patient opens like this, and we look and there's a tongue and spit, how are we to assess 10 degrees in on one side compared to the other? To know that this is what's causing the deviation of the mandible to the side. Okay? Look there because you'll see it. This is Janine. So we had a nice smile arc here. Now, I did a little bit of laser in her midline tissue because she was a little bit gummy. But you can see the nice change in her facial aesthetic and her smile arc. So even though I lasered in the midline, I could have done a little bit more to address some of her passive eruption problems. I always look at every case. I don't think I ever love any case, like think, oh, that's perfect. No case is perfect. And I want to stress that too, because we all have this complex, the orthodontic complex, which is to try to be perfect. But we should never try to be perfect. We should try to be excellent. And trying to be excellent means you're trying to be better. Trying to be better than you were yesterday. Compared to you, not compared to anybody else. We're all on our own journey and working towards what we can see, how we can get better, what we can learn from each other, how we can share information. This should be the focus and the foundation of our profession. Okay? So I could have lasered more here, and I should have, because it would have given me a better height to width ratio of her anterior teeth. I've spent a lot of time this year studying microaesthetics, things that I overlook when I'm looking at these cases now. When I put them up on a big screen like this, believe me, you get a big reality check sometimes. It's not as good as you thought. So her treatment summary, Janine had 11 months of treatment. She had 7 visits, including her banding and deband, 1 bracket repair. She had custom SL, Excelident, disarticulation, elastics, stepwise progression through her custom arch wires. I did no repose on her and no curves, and she had 1 bend. Total clinic time, 3 hours and 10 minutes. This is Janine, the day I put her braces on, as we went through. Now here, Chris, you'll be unhappy with me. The pictures were on vacation that day. This is her deband day, the day I took her braces off. So this is simple. This is what I mean by simplified mechanics. Because I have an assistant, my hygienist, who will glue the braces on. They're glued on indirectly. And I will sit down and say, put the band lock here, and then I have to take it off here. And I say, wear some elastics like this. I do a little laser, I should have done more. And then I clean the glue off. That's pretty easy for me. Okay? And I could have maybe put a little more step on her when I did a step bend on this tooth. So, and look at the nice change here, periodontally. I mean, she's thin here and she might need a graft, but it didn't get worse. And I rarely see that. We can control that so nicely with Insignia. We're not straining the tissue. It's not taking long in her braces, which can be bad for things, right? She moved through it nice and quick. So what else do we want? Remember our goals. We want to solve the teeth and remember her smile and make the jaw joints happy and pay attention to the periodontal tissues, right? Remember, we want roots in bone, right? Don't we? So we have to think about all these things when we're doing our setup. So this young man came in, and again, now I want you to see this because you will see this now on every case, and this is what I like to say. Once you see something, you can't unsee it. Once I saw that Damon doctor's cases, I could not unsee it. I could not unsee that this is going much different than what I've learned. This is looking much better than what I'm doing. I need to find out how to do that. And now, when you look at your cases, you will see this. Right? And almost inevitably, the side that is tipped in more has a blocked out cuspid. It's eerie. It's like a pattern. We see this now all the time. You will see this all the time now. This side needs something different than this side. Okay? And we look at this case and say, okay, this is him when we started. Andrew at the top and Angie at the bottom. And look at Andrew's inclinations here. So you deal with class 3s a lot. And class 3 incisor compensation is not good periodontally, right? It brings the roots out. And what do we want? We want the roots in. Andrews describes the Waller ridge, and that's what I'm looking for. Okay? This is him on the day of his D-band. Now, I missed a bit here, right? I left his band lock on this day. I didn't take the glue off on his posterior teeth for some reason, so this didn't close. But what I wanted to show you is this periodontal health. We want the roots centered in the bone inside the Waller ridge. And Waller stands for Will Andrews and Larry Andrews. That's Larry Andrews and his son, Will. And when they developed the 6 elements of orofacial harmony, if you've read this paper as well, although this one I feel like is less known than the 6 keys of occlusion. The 6 keys is like, boom, everybody knows the 6 keys and it's like, yep, we got that. But the 6 elements of dental-facial harmony describe this. And I remember hearing Dr. Andrews speak and said, if you looked at a cast of the teeth and you look down at the teeth, you should be able to see the widest portion of that mucogingival line is a ridge of bone, and they called it the Waller ridge. And you should see that surround the teeth. So if your teeth are flared and you look down occlusally at that cast, you will not see it. Okay? And so this is sort of how they're looking at where the lower incisors should be positioned. So I built no compensation into these teeth. Remember, for good periodontal health, we do not want compensation in the incisor positions. So don't, when you're doing insignia, get your class 3 patient and think, well, he's like this. I'm going to leave the lower incisors tipped back and the upper teeth out because I think I won't get all the way there. This is what I hope to get. Well, let me tell you, that's all you're going to get. You will not get the roots upright, even though you want the roots upright. Ask for what you want. If the patient is growing poorly, if they need buccal shelf screw TADs, if they need something else or surgery, then you can do surgery. But you know that as the orthodontist, you are choosing the best position for the teeth. That is always the goal. Set them up always with ideal inclinations. And what does that then mean? One setup. Ideal looks ideal. Looks like this. We do it all day long with our hands, right? This is very valid. This is how incisors look. We don't want this. Because a class 3 incisor, when they're flared on the upper, what happens to their smile arc? It's flat, right? We lose then. So we need upright in order to have a smile arc. Do not decide in your mind what is possible before seeing what is possible. If I set up ideal, then I know that I have a chance, in this case, of getting ideal teeth without doing anything other than putting the braces on. There is a chance that the case will go there. If it stops, then I can identify what is stopping the teeth from going there. Look at the change here and here. So this is what I set up. Look at the retrocline lowers on this boy. His teeth are laying down. They were like at 72. And I set like this. Look at his molars. Remember, he had more collapse on this side, and that's what was causing this tooth to be blocked out. Watch the curve of Spee that develops on him. And a gigantic curve of Wilson. and we level this, a lot of the curve of Spee here is leveled by uprighting the posterior teeth. What made this boy's case so easy to get this was the movement here of the lower molars. Because if I left the lower molars rolled lingual, I could not have gained enough space to align the lower teeth, nor open the bite as much as I needed. Because look how deep the bite is. Look how deep the anterior overbite is. This is Andrew as he's smiling, and he's pretty strong in the jaw. And we talked about surgery, his strong jaw. If he didn't like his chin, he loved it. I love him. He's gorgeous in person. And I would say this, he is facially asymmetric. He is a facial asymmetry. How do you know? Because you can see his eyes and his nose. Not just this cant, because the reality is that this little bit of cant in his upper smile arc is my fault. I set the teeth incorrectly there. I missed the torque on his 2-3. However, that kind of asymmetry, when we can fit to the framework and use ideal inclinations of the lower teeth, reliably, consistently, with very little work. Now, his teeth took a little bit of doing. He took 18 months. This is a long case then in my office. 11 visits, including banding. Sorry, I'm going to go back. 11 visits, including banding and deband. He had insignia custom SL, an Excelident, disarticulation, elastics, stepwise progression. Are you getting the gist of this? How simple? I did no repose on him. Did you see his lower cuspid? His lower 3-3? I didn't have to reposition a bracket. Now, you could have said, I missed the 2-3. I could have repositioned that bracket. He wasn't closed on the 6. I missed that. But the tough part of his case got sorted out. The really tricky part. Reverse curve, I did add to his lower arch wire, and on him I could have gone to a 21-25. And I added torque springs to his upper and lower cuspids, individual torque springs, Warren springs, and the upper laterals. His total clinic time was 3 hours and 30 minutes. This is him as he started, and the day we put his braces on. Now here. Now, you see this, visit 3, 1, 2, 3. This is here where I'm looking at a patient and say, am I going to solve this? Look at his overjet. You know what I learned in school? If you put braces on those lower teeth, he's going to have a huge what? Underbite. Right? He didn't. He never got an underbite. He had overjet. It was totally under control. Nothing weird happened in his treatment. And all of this, just letting this wire work out. And I added torque springs here. So what about Dr. Damon's adjustable torque base for braces? I love that. It would save me doing this. Because torque expression, this is where I still have a job. I have to evaluate what am I seeing, what needs more or less. Do I have to add a spring? Did I get enough torque expression here? But look how upright this tooth is and the alignment of the lower teeth from that in just those number of visits. And level. So, we want to solve the teeth. And remember the smile and make the jaw joints happy and pay attention to the periodontal tissues. And don't forget the face, right? Because we have all of these things. These are all of our goals. And we can't lose sight of one of them. And this is the tricky part of finishing. Because when we are faced with appliances that are standard, our minds are sucked into working out the deficiencies in the system. Not achieving the goals of the treatment, not evaluating, does this all look perfect and right, and is it going to function properly, and how am I doing with the perio, and is the smile looking good? We are sucked into, how do I get these arches to coordinate? How do I get this transverse problem to sort out? Accuracy is efficiency. Being accurate. So, variable torque is more accurate than just putting the same thing on everybody. But repositioning is a big issue. Every time we have to reposition a tooth, we started with a crooked tooth. How do we expect that our models are going to fit if something is crooked? Just like I say, you take straight teeth and move them so they're slightly not straight and try and put them together. Okay? So repositioning slows us down a lot. Bending slows us down. All of these things have different side effects. Coordinating our arches, okay, making sure that all these things will work together. Changing directions. When do you want to change directions with a patient? At month 4 or at month 24? At month 24, it's over, you know? The patient is done with you, and they've lost faith in you usually, or you're just like worried, you know, this is going on 3 years, how am I going to get this done? We know what we want to get for the patient, but we're not quite sure. Those changing directions cost a lot for us for clinical efficiency. Thinking, how tired I used to be after a day of work. Mental gymnastics to go from patient to patient to patient, and every third or fourth patient, there's something not quite working out. It's just not right. I think, you know, I'm just like, how bad could you feel? Like I felt incompetent. I thought, I'm trying my best. I think I'm pretty good, but I just can't get it. I don't know how to get these teeth to come together. Why this is such a mess. It's like, can someone show me a good case, but then I can't reproduce it. I teach Insignia at the university. My residents could publish their cases. They look beautiful, because they finish them even better than I do, because I make them, like, reposition that one, do this, you know? Make the treatment take 18 months, and finish every little finicky thing. They're absolutely beautiful. The number of treatment visits affects our cost per visit, right? How much money we're making, how much is the treatment costing us to do? The more times a patient has to sit down, the more costly it is to you. And your treatment duration will affect your clinic capacity. How much can I do if I have a 1-year caseload? This is my goal. Is when I started with Insignia, about 3 years ago, I decided I need a 1-year caseload. I had a 2-year caseload before then. It was actually over 2 years. It was 26 months was my caseload, meaning whole 2 and a bit years of patients were active in braces. Okay? That's a lot to manage. That's a lot of phone calls. That is a lot of visits. I take that same number and I whittle it down, and now my active caseload is at 14 and a half months. But it needs to go under 12 so that I can increase production without working more days, hiring more staff, having more chairs. That's what I want. So these things, Insignia is very, very profitable in that way. Remember, mechanics is not simply something that's done once the braces are on. It's every step we take to solve that puzzle. If I gave you a Rubik's Cube and you just start moving it at random and cross your fingers and hope you get the solution, I got news for you. You're not getting it. You need to know the system. You need to have a system in order to make it happen. The more steps we take unnecessarily, the more costly it is to both the doctor and the patient. And by studying our solution, this one class 1 solution, we all know what this is. We as dentists all know what a class 1 denture setup is, and we are doing full mouth reconstruction with a natural dentition. That is what we're doing. We start with the upper central, the way Dr. Burney said. Everything that I do now makes sense to me periodontally. My prosthodontist would put implants there. I'm not putting buccal root torque with a TPA. No implant dentist putting teeth in like this, okay? Everything I'm doing now is so consistent. And when we study the solution, we're gonna see some surprising things. I learned something with Ashley, this girl. So, my class 1 setup, same, looks the same. It gets boring after a while. I can hammer out a setup in 15 minutes. I can show you on every one of our setups where you miss some teeth, where they're crooked, and how long have I been doing it? 6 years. I am a far better orthodontist now than I was after 12 years of work, the first 12. I am, because I actually know what I'm putting on the teeth and how to get there. Look at this girl's teeth. Watch the collapse here. Watch this tooth. Look at her midline. Look at her transverse dimension. Picture the labial musculature moving in and collapsing the teeth. And look at this view. Look what happens over here. Not only did I started to really, really focus on this because this is common. It's common to every patient that has any kind of moderate malocclusion. Class 3, class 2, doesn't matter. Their lower teeth do this. And I looked at that and I thought, look at all that uprighting. That's what Dr. Damon's talking about. And I'm going to prove it for Dr. Damon. I'm going to get a math team to show me how much space I gain, how I can fit these teeth in. So this is Ashley. She's class 2 div 1, right? 11 years old. She has bimaxillary protrusion. And look at her lips. She has her teeth stick out, and she for sure does not have the giant Asian teeth, okay? Bruce and Colin said, Sonia, if you could find some extraction cases. I said, one, I'm in the center of Oxford County in London, Ontario, Canada, okay, which is the dairy capital of where I am, okay, in southwestern Ontario. I'm in a huge Dutch population. There are not many Asian teeth there. There just aren't, okay, in my neighborhood. And I said, I can't remember the last time I took teeth out. I can't. Because Caucasian teeth are very average size. This is her face, though. Look at her face and the Bimax on her. Look at her lips sticking out and her teeth sticking out. This is her overjet. Her teeth are way out. Look at the perio on this tooth. I guarantee you, this girl got upper bis or 4 bis in my clinic 15 years ago. 100%. Like, boom. Like, her teeth don't fit, and we got to take teeth out, and Mom's like, yeah, I know, we knew. You know, there's just, that was a given. Now, I have the option, right, with these protrusive lips, this midline and this blocked out 3-3, and her overjet. What I want to show you is this transverse. Those 6 lower anterior teeth have to fit in that distance. They have to fit underneath the upper 2 to 2, right? That's a class 1 occlusion. So that we have cuspid rise. And that's how narrow she is, even though she's not in crossbite. Now, do we extract for this type of face in every situation? Well, guess what? I get to do a setup. I get to set up her teeth. I get to see the trough and see if the teeth fit, and I get to move the teeth there and determine if I need to take out teeth. Because, to be honest, I've seen lots of lectures around the world, and my thinking is this. If I see an extraction case of bicuspids, and there is 4 millimeters of extraction space to close per side after the alignment of the teeth, that patient did not need teeth out. I will say that. That patient could have accommodated all their teeth. And it was simply that the molar movement that was necessary to address that problem was overlooked. And here's why I say that. So I was so excited to prove Dr. Damon's uprighting the posterior teeth to transfer the anterior crowding. This is the formula. This is from a math team. Now, this formula here, okay, right here, describes the space that's created when we upright a tipped tooth. So, what did I learn from this math? Because I thought, oh, this is going to give me tons of space, right? This is what he's always talking about. Uprighting, transfer the anterior crowding to the posterior uprighting. For every 10 degrees of posterior uprighting, and that is bilateral, so if you take 2 lower first molar teeth and you upright them 10 degrees, you will create 2.5 millimeters of arch perimeter. That's not enough for a cuspid. I did this, the first math, that 4-page calculus derivative, I got that done, and I said, that can't be. That can't be right. I went back and I looked at my approver, and I thought, what else is happening? Where is the space coming from? And it's this. For every 10 degrees of tip on a first molar tooth, and in a Caucasian, the average first molar is 11 millimeters mesiodistally. For every 10 degrees that you upright this tooth back to a vertical position, you will create 3.3 millimeters of space. That's shocking. We cannot see 10 degrees. You can only see it on that movie. It looks so dramatic, you know, and why? Why do I tip the teeth up and then upright them this way? Because I need a level curve of speed. That's not, do I want to move the teeth in order not to take the teeth out? That's because I have to move the teeth there to accomplish the 6 keys. It's not random. I don't decide. That's the ideal norm. So if I put those teeth there, this is what I'm going to get. Now, Caucasians have smaller teeth than Asians, so I'm imagining that if an Asian tooth is bigger as a first molar and it's tipped forward, it's taken up more space. And these teeth are all tipped forward and in. And so our traditional crowding assessments to measure from the mesial to the mesial of the lower first molar, when it's tipped forward and it just needs to upright, we have to add back in this kind of spacing, because to upright 2 lower first molars, labially and tip them distally, just 10 degrees is enough room to get in a blocked out cuspid. And math doesn't lie. Math is math. The creation of space when the mandibular occlusal curves are leveled are mathematically true. And I spoke about this. I attended Dr. David Sarver's course, and he said, Sonia, you have to publish this. And I said, yes, in my spare time, I'm on that, you know? But I'm sort of like you, and I think I'm sharing it, and I'm going to try, okay? I will try to make a paper and to put it so you can read it, okay? But here I am to tell you, okay? We account for this movement, and we can see it in the Insignia digital platform of Approver. You can see the tooth movement. Why? Because it's easy to see a tooth, a point of movement of 10 degrees from A to B. You can see it when it's moving. But if you just say to a patient, open your mouth and look in, and you try and see, oh, your molars are tipped forward 10 degrees. How are you going to see that? You're looking at the 6 and 7 marginal ridges. They're both tipped forward. They look straight. Okay? And her molars don't look forward or dumped in, her lower molars. In the majority of cases, it appears that the molar movement, to me, it appears that the molar movement has created the anterior distortion, and it can simply be undone with proper appliance placement and design. My analogy is this. You're making the bed. You grab the covers, and you do that, right? This is the molar. I move the molar, and what happens? A train wreck happens at the front. Because my molar moved just a bit, boom. And what happened at the front? A big movement. Because those teeth are sharing covers. When this guy moves, he's a bully. Everything's going to get messed up. So do a setup and see if the teeth can be accommodated prior to extractions. How do we do it? I say, well, you got really big teeth. Ashley, I don't know that I can fit all your teeth in and meet my treatment goals. I'm going to scan your teeth and do a setup. And if I see that your teeth are not going to fit, I'll change my setup, and then we'll send you and you can have some teeth out. I haven't had to take out any teeth. This is the day that I started Ashley. And this is the first time I did this. Now, I don't want to do surgery on Ashley. I just want to keep her teeth. I put her in an 014 and light class 3 elastics. And this is the key to all of these patients. This is what I want you to look for right here. When you have a blocked out cuspid and these teeth are all tipped forward, the first step is not to run a class 2 elastic on this girl. Do not run a class 2 elastic on this girl. If you do, you will not be able to fit the lower 6 anterior teeth into the upper 6 anterior teeth. It will cause more mesial tipping of your lower molar. You will not upright that tooth. You will not take advantage of this space that you will gain. You will not correct the problem. And I had a small heart attack when she left the office because she had a very large overjet. And she could not close her lips at all. And I said, I think we're going to try and keep your teeth. we're going to wear your elastics like this. And my hygienist was like this, like on the computer screen, like behind her head, you know, where it said orthopedic, non-surgical. She's like this. Because she thinks running this class 3 is what we would do to decompensate a surgery patient. Have you ever done this, though, on a surgery patient? Run a class 3 elastic, and they came back better. And you thought, oh, we got to decompensate them, right? This is why. This is this light early class 3 for 10 weeks. I used band lock to disarticulate her. And what I would do differently with her, I would have put that glue on her 7, on her lower 7, probably today. Because her lower 7 was really, really tip forward and it needed to tip back. Then by placing the band lock selectively on the tooth that you want to intrude the most, because you know that that tooth will go up, right, on the glue. You think, oh, this tooth's going to come down as much as this tooth moves back. No, it won't. Because the glue is holding it up. And what do I tell Ashley? Squeeze on the glue. Bite hard on the glue. Count to 10. 1, 2, 3. Put your lips together. Okay? This is what I tell her. And I run it in the direction of the lower first molar movement that I want. So my selection for early light elastics always is in the direction that I want the lower first molar to go, especially with a blocked out cuspid. Because I guarantee you, on that lower blocked out cuspid, your entire buccal segment is tipped mesially. And the space comes simply by uprighting this side. And note the retraction of her upper anterior teeth. Her upper teeth came back. Why? Because she was biting. Because we flattened her occlusal plane, and I told her to squeeze her lips together. A light force moved them out, and a light force will move them in. And that is all tipping. And that's why it happens so fast. So this is her the day she came back. This is on her first visit back after her braces. Okay? And we put in our 1425 custom, and I started her just some light class 2 slingshots. Like this. Now, elastics are overrated. And elastics are something that I feel like have been handed to us as like peas and carrots, like braces and elastics. Like we all need elastics all the time. And I think that we hang on to using elastics because we feel like we have to do something, but almost always there's an unwanted side effect from elastics. And so largely my thinking these days is, how do I stop using elastics? How do I never put a force on teeth that will give me an unwanted movement? Because that's round tripping. If we want to go faster with less visits, we should design a method so that we don't have an unwanted side effect. There has to be a way. This isn't sending someone to the moon, but this is what is her. So with Ashley, I did no repose and no bends or curves to the arch wire, and this is the day I took her braces off. She had 13 months of treatment and 7 visits. And I did a temporary buildup on her 1-1. She had this weird wear, if you remember, and I should have done one on the 2-1. I don't know why I didn't. She had a chip out of the 2-1 as well. But that's the day we take her braces off. Look at the cuspid position right there. Do you see when you look down, this is the Waller ridge, this ridge here. Do you see it? You can see it around her anterior teeth. This is what to look for so you know how flared or forward your teeth are. This is her overjet. This is her curve of SPE picture. And this picture, this is what I found when I have been incomplete in posterior uprighting. If you look at a case and you take a curve of SPE picture and your midline does not come on, what do we say? Well, your articular eminence, they're probably asymmetric, or your condyles are asymmetric. We don't know. That when you go forward, you move to the side. Okay, she moves to the side because of this transverse problem that she has. When you address someone's transverse problem properly, 99 times out of 100, they become symmetric and their midline comes on. Because the mandible likes space to move. It likes range and motion. It needs room to move to both sides. And when it comes forward freely and the midline stays on, the jaw will always move more to the side that it's easiest to move to. If one side is torqued in, it will move away from that side. Okay? And so when we look at this overjet picture and say, well, this is what I had planned, and you'd say, well, that's not going to move all that distance and all this in just about a year. I didn't reposition anything. I didn't bend anything. We glued braces on and took them off and had to wear some elastics. I'm liking that. I'm liking what I see there. And then what about her face, right? Because we were saying, well, we need to be able to retract those teeth. That's her change. Now, remember the other girl with her nose really turned down and her face was pulled in. She's like, you can see up her nose when she was walking in the office, okay? And look at the subtle change in her nostril position. Okay? So when we look at her E-plane, both her lips are touching, and then here just her lower lip is touching. She has lip competence, profile balance. The lips to the E-plane are where they need to be. The tip break on her nose has changed, and it actually changes the anterior form of her nose. Why? Because her anterior nasal spine moved. How? Because we moved the roots of her teeth? Because we moved her teeth? There was alveolar deformation. That bone is soft. It just moved out. We just moved it back. The forehead line to the position of the nares. This I like. She's all by max. Look how pushed out she is. And we had not, remember the other girl, her nose was so far back, behind? And now it's like this. And this commissure, the border of this lip as it falls down, it should roughly run like that, so that this and this is slightly larger than this. Do you see here to here? She has nothing. So this muscle, there is a muscle running from our nares to the corner of our mouth. It's the elevator. It's our smile muscle. And if this is not in balance, the smile does not look the same. So evaluating smile aesthetics on our problem patient, how is that a fair assessment? Why are we so obsessed with the problem? Let's get in line with our solution and start thinking about how to solve this. Because when we see here now, I didn't forget, and I got her teeth down to her lip line where they follow the lower border. And when we look from her forehead line that Andrews described, this is again part of the 6 elements, that we want that facial surface of the upper central to be parallel to that forehead line, and also to fall on or within 1 millimeter anterior posterior of that line. So we treatment plan from that upper central back. We look at the lower molar and the upper central. And I didn't need any extractions to achieve retraction of her entire dentition in this case. And what was the key to me was a class 3 elastic on this girl. Did you see? It unlocked her problem. And then I was able to just adjust her dental basis so simply. Because I'm like Dr. Lin. He doesn't want to have to put in 4 screws, and I don't want to have to put in 2 screws. I'm even lazier. I don't like to do too much. I like to have a nice dress on and have a good time. So look at the change here in her nose and in her lip balance. The upper lip to lower lip ratio of 40 to 60, it's 40% to 60% upper to lower lip is restored, not so much from thinning of her upper lip, but a thickening of her lower lip as we eliminated her lower lip trap. Look at the balance now of her nares here, and this change here to here, from tooth movement. And why is that so important? Because on this face, it makes us think the patient is so skeletal. And I can tell you that A point is unreliable for that reason. That will distort everything. If all I care is what this is about, instead of looking what I want here, I'm focusing on the wrong end. And this is what digital has done. Ashley's treatment summary is this: 13 months. She had 7 visits, including her banding and deband. Insignia Custom SL, Accelerant, Disarticulation, Elastics. A stepwise progression through her customs. No curves, no bends, no repos. 3 hours and 20 minutes. And this is her case. And this picture specifically, I never take the pictures with the elastics on, and again, I'm sorry I missed one here. But look, on with the braces. 1, 2, 3. Right here. Would you like that? I like it. I can tell you that I like my clinic life, because right here, from here to here, do you know what the conversation's like with Ashley's mom and her when they walk in on the 3rd visit? Look at her face. Look at my daughter. Look at the change. My bite is starting to feel so good, Sonia. This is such great work, and we're almost done. These are the conversations I want to have. This is predictable. Anyone in here with a good setup and an understanding of what we're trying to accomplish can do better work than me, probably, if you can get a good setup. As good or better. This is not specific to me. This is not because, in a sense it is because I'm good at a prover. I am good at the setup. I know how to look at computer teeth to get straight teeth, because my goal is I don't want to touch the teeth. And I'm working on even microaesthetics, how to get the teeth exactly what I want to see. Beautiful. I'm working on the artistry of those teeth now to try to dial that in so that I just love it. Now, what about stability, right? It's the sum total of all of these goals. When you look at a study that says nothing is stable, well, let's just kick it in. I mean, nothing is stable, right? We have obviously consideration for causative factors. If you're a mouth breather and you're still a mouth breather, you're going to have the problem, okay? We can't solve those things. What are the current conditions and what caused the malocclusion? Factoring in normal aging and deterioration. Let's, as a group, realize that retention is maintenance, and it's a part of life. No one goes to the eyeglass doctor, gets glasses, and see you later, and you're good. Oh, and can you come back in 6 months, and I'll make sure you're wearing your glasses? Your doctor says, see you later, and if you lose your glasses, you have to buy new glasses. And they don't care if you don't wear them, then you can't see. But orthodontists, it's like we own the teeth. It's like we own the problem. And so being able to get the teeth together tightly from the day I take the braces off and know that I have these abilities to look at things in ways I didn't before and understand that this can then translate to stability, that I don't ask people to wear a full-time retainer. You will just sleep with it. So that I know there's more chance you're going to sleep with it. But I know here that if your teeth fit, you have a better chance of it being stable than if they don't touch. If your teeth don't fit and I have to float them down and hope they come together and that you wore that retainer full time for a year, probably not. So, Insignia allows us to practice implementing these goals into our solutions, and we can then study the results and determine what, if any, shortcomings in the treatment were actually related to. So much of the conclusions and the truth in orthodontics is based on incomplete appliances, inadequate appliance therapy. And they're erroneous, those conclusions, and they let us down the wrong path a lot of times. We need to look at these things and determine what is it, if it didn't work out, was it the appliance design, was it a patient factor, or was it my clinical technique? It's one of those. Insignia allows us, sorry, I have to play you my little shimmer again because I double-clicked it. Insignia lets us do this. It's possible to simplify mechanics pulling the patient from the initial malocclusion to the desired endpoint rather than trying to push them there. Traditional orthodontics parks you with the problem and you try to steer this problem to what you think is the end. Instead, we position ourselves in the solution. We study this and this only, and I will pull you here. And I'm not chasing the problem anymore. It allows us to start with the solution and focus on the finish, which for me is now. Thank you so much for your kind attention. $2.59.
Perfect. Perfect timing. Thank you very much, Sonia. Always fun to listen.
Good.
Look, I'm sure many of you may have questions after looking at Sonia's presentation, always when new things are introduced. So please look for Bruce, Sandra, or myself. Sonia will be here for the rest of the meeting, so please feel free to come and ask. And if any of you are curious and would like to try some insignia, we have a very solid process and support team to help you through your initial cases. So please, if you're interested, just approach the OMCO staff. Thank you. We're going to take a half an hour break.
Thank you.
Great job. Great job.
Thank you.